anatomy and physiology. I'll go over some basics of MR lymphangiography and some techniques. Then I'll show some cases of how we use it in single ventricle. And then at the end, I'll go over some potential uses of lymphatic imaging as an imaging biomarker for Fontan surveillance. So briefly, lymphatic anatomy and physiology. Let's think about what is normal lymphatic anatomy. The lymphatic drainage in the abdomen all comes into the cisterna chyli, which feeds into or continues on as a thoracic duct, which receives lymphatic drainage from the thorax. And this dumps into the left venous angle at the confluence of the left internal jugular vein and left subclavian vein, usually. On the right side, you have your right lymphatic duct, which drains the right head and neck and right upper extremity and portions of the right thorax. So the thoracic duct carries about 80% of lymph to this left venous angle. And this is just what I already said. It basically drains the cisterna chyli, the thorax, and the left head and neck and upper extremity. And the three main tributaries to the cisterna chyli in the abdomen are the retroperitoneal lymphatics, the central hepatic lymphatics, and the mesenteric lymphatics. But this isn't like a perfect anatomic relationship. There is some overlap between these territories, and there can be some anatomic variation. So let's think about what is normal lymphatic physiology. Lymphatic uptake and flow is driven by passive hydrostatic and oncotic pressure gradients. So flow in the lymphatic vessels is normally promoted by arterial pulsations and muscular contractions, and this is augmented by diastole and inspiration. There are valves in the system, including at the thoracic duct venous angle, and this prevents retrograde flow and backflow of blood normally. And this is important because lymphatic vessels are very prone to thrombosis if they contact blood at all. So you can already imagine how this is pretty bad in a Fontan situation. So after Fontan, you have this elevated central venous pressure by necessity. You also have loss of the diastolic effects, which I've mentioned, augment this lymphatic flow. This can lead to lymphatic dilation. You'll have incompetence at the valve, and that can often, or not often, but it may lead to obstruction or even occlusion, complete occlusion of the thoracic duct. In addition, as you know, there's universal Fontan-associated liver disease. You could have PLE or even subclinical PLE. All of these things can lead to decreased oncotic pressure, which also is bad for maintaining this pressure gradient. And in the late stage, you can have end organ failure and fibrosis of multiple systemic organs, which also leads to more capillary leak, which is causing more stress on the lymphatic system, which is required to absorb all this interstitial fluid. And basically, in the Fontan circulation, you're asking the lymphatic system to drain to a pressure system which may have a higher pressure than the pressure gradient that was originally existed to create it. You know, here you're looking, in this example, the pressure gradient is 16 draining into 14. And you can imagine that that could be a little different in certain scenarios where it can really make the lymphatics function poorly. So let's go into the basics of how we can image the lymphatics. In our practice, there are two main indications for lymphatic imaging. One is in the Fontan or single ventricle population, and the other is in congenital lymphatic malformations. And we do quite a bit of both, actually. I'm going to focus more on the single ventricle population in this talk. What are we looking for? There are two main things. One is the anatomy, so the anatomy of the thoracic duct and the central conducting lymphatics, the presence and location of the cisterna chyli, and then the distribution and severity of the lymphatic congestion or ectasia. Then the more interesting part is the physiologic information we can get, which is dynamic visualization of lymphatic flow, which can often help let us understand the nature of the abnormality. So accurate diagnosis guides medical treatment options and identifies target for possible catheter-based intervention. What can we use to image lymphatics? There are a lot of different MRI sequences that have been described, but I guess the main ones that people think about when you talk about MR lymphangiography would be this heavy T2 weighted. Sorry, I'm getting a text about an MRI we're doing right now. 1 second. Sorry. So this heavily T2 weighted 3-spin echo sequence, which gives you fine anatomic detail, but is a longer, somewhat long acquisition. And then this dynamic contrast enhanced MR lymphangiography, which is gives you that physiologic information, but is an invasive procedure combined with catheter or catheter intervention, or either with interventional radiology, or you can cardiac catheterization colleagues. So here's an example of the T2 weighted MRL. This is a Fontan patient with profound lymphatic abnormality. You can see that this is the source images, and this is a kind of a maximum intensity projection of these source images. It gives you, basically, you can see how crazy the lymphatics are in the supraclavicular regions, extending into the mediastinum, into the lungs, and even in the liver, mesentery, and retroperitoneum. There's a ton of lymphatic ectasia, proliferation, and congestion. So this is like a sample technical parameters for this sequence, but basically this is a widely available sequence. Anyone can run it. It's been used for years by radiologists for MRCP. So I'm 100% sure you can run it right now today if you wanted to. And there are a few things you could do to optimize it for lymphatic imaging, but you don't need to do that. The out-of-the-box sequence will work perfectly well. So in my opinion, T2 MRL should be routine for all single ventricle pathway CMR, and I'll give you some data for why that could be the case later in the talk. Some groups have done some interesting fusion of this data set with angiography, so you can see the precise relationship of the lymphatics with the cardiovascular structures. But this is just for show and tell. It's not really that clinically useful, because we can just do that in our minds. Okay, so let's go into the more interesting part, DCMRL. This is when we actively inject contrast directly into the lymphatic system and then image it. And there are 3 ways you can access the lymphatic system, at least 3 common ways we can access the lymphatic system. That would be intranodal, through the intranodal groin lymph nodes, through the intrahepatic lymphatics, or through the intramesenteric lymphatics. And as you recall from earlier in the talk, these are the 3 main tributaries of the cisterna chyli. So then after you start injecting into those lymphatics, you can get, you start imaging, and basically you track the passage of contrast through the lymphatic system. And there are a few ways you can do this, either through a time-resolved 3D spoiled gradient echo sequence, or you can use sequential spoiled gradient echo variants. And both of these have their advantages and disadvantages. Finally, you can finish this off with a high-resolution static imaging of lymphatics. Often we'll do a respiratory navigated 3D IR spoiled gradient echo. So I'll show you examples of all of this. So this is accessing the groin lymph node. So by ultrasound, you put your needle into this lymph node, which is quite small. It's about 1 centimeter or less in short axis. Then you cannulate both groins. This is in a dummy. So you cannulate both groins and then go put them into the scanner. And while in the scanner, you slowly inject this gadolinium. And this is what you see. You can see that this is normal, where you have uptake into the iliac and retroperitoneal lymphatics, into the thoracic duct, and then dumping into near the venous angle. So normal hemodynamics of the lymphatic system, in 2 to 3 minutes, you'll have uptake into the iliac and retroperitoneal chains. By 5 minutes or so, you'll get the cisterna chyli, and then by 10 minutes, you should get up through the thoracic duct, and then late it'll wash out. So that's normal. This is how we access the hepatic lymphatics. You have your needle coming into the periportal regions where there is periportal lymphatics. In the same method, you confirm your placement by fluoroscopy, and then once you have that, you go into the scanner and you inject just as before. Intramesenteric lymphatics is the same way. You find the mesenteric lymphatics by ultrasound. You can confirm positioning by fluoroscopy, and then this is what it looks like in a normal case, where you have uptake into the mesenteric lymphatics, which feed into the thoracic duct and go up to the left supraclavicular region. So this was a recent paper that introduced this technique, and they compared intranodal, intrahepatic, and intramesenteric DCMRL in 15 patients. And what they found was that they don't show the same thing, right? So if you're looking for dermal black flow or you want to visualize the thoracic duct, the intranodal DCMRL had the highest yield. For PLE, not surprisingly, intrahepatic DCMRL had the highest yield, whereas peritoneal leak intramesenteric was the best. But the more important point is that there wasn't 100% overlap between these techniques. So you basically need to interrogate all the tributaries to the cisterna chyli to really fully evaluate the lymphatic system. So in my opinion, they're all complementary, and you can tailor your exam to the indication or what you suspect is going on. So in summary, the T2-MRL technique is non-invasive. You can run it on any routine cardiac MRI. It gives you anatomic information only, but is very simple, and you can run it today if you wanted to. The DCMRL is invasive. It requires more specialized expertise, but it provides dynamic pathophysiologic information, which can help guide treatment. So let me show you some examples of this. So first, let's talk about plastic bronchitis. So I know I heard we have a mixed audience here, so I apologize if some of this is basic, but what is plastic bronchitis? So it's a production of thick bronchial casts, which are expectorated. And in Fontan, the composition of these casts includes inflammatory cells, fibrin, and mucin. And so how is pulmonary lymphatic flow abnormal in Fontan patients with plastic bronchitis? Well, as I've already alluded to, the normal situation is you have your thoracic duct going up into the left venous angle, and you have normal tributaries that drain into the thoracic duct from the lungs and from the head and neck. In Fontan, however, the lymphatic system is impaired or susceptible to congestion. You have congestion in these tributaries, and in plastic bronchitis, you can actually have retrograde lymphatic flow to the lungs. And often it actually looks kind of like this. You have a lot of ectatic abnormal lymphatics that just go everywhere, including into the lungs. And this lymphatic fluid becomes secreted into the airway. So during bronchoscopy, here there's injection of isoflurane blue or dye into the thoracic duct, and within minutes you can see this blue staining the mucosa of the bronchi and eventually coming into the actual airway, which this will once it contacts air, it'll denature and form casts. So just to summarize, you have your elevated central venous pressure in Fontan, and all those other things I listed before, which make the lymphatics vulnerable. This in certain patients can lead to retrograde lymphatic flow to the lungs. This leads to lymphatic leakage into the airway, and this forms bronchial casts and plastic bronchitis. There may be some inflammatory triggers, as this can be exacerbated, for example, by respiratory infection. There are some modulating factors, such as probably the pattern of lymphatic collateralization. And also, there has been some research that's shown there's some congenital susceptibility, especially, for example, patients with plastic bronchitis have been shown to have deficient immune regulation, speaking to some of that inflammatory component. So what does it look like? On CT, you have heterogeneous bronchial material in this patient with plastic bronchitis. You can see bronchovascular ground glass opacities, which to me is lymphatic leakage. You have more evidence of this heterogeneous hypodense material in the airway. And you have bronchovascular soft tissue thickening, which reflects lymphatic congestion. This patient got worse over time, and you can see these confluent bronchovascular ground glass opacities. This is more lymphatic leakage into the airway and also into the small alveoli. So CT findings in plastic bronchitis, you have heterogeneous bronchial material forming bronchial casts, lobar collapse from airway obstruction, bronchovascular ground glass opacities from lymphatic leakage, and bronchovascular soft tissue thickening due to abnormal lymphatic networks. And sometimes this can be exacerbated by infection. What do we see on MRL? So this is a T2 MRL, it's the anatomic information only in a patient with plastic bronchitis in the Fontan. And you can see that there is quite abnormal retroperitoneal, mediastinal, bilateral perihilar, and supraclavicular lymphatics. When we inject into the groin, you can see much more abnormal looking lymphatics, which are dilated and ectatic. You can see it goes up to this thoracic duct, which this is probably not the normal thoracic duct, but a collateral going up to the right side. And then there's a ton of congestion, backward flow into the lungs, causing plastic bronchitis. And this is the high resolution sequence, which shows all of the anatomy nicely. So we see a network of abnormal dilated lymphatics with retrograde flow to the lungs. Sometimes this is termed pulmonary lymphatic perfusion syndrome. This patient also, you can see, has a trace effusion on T2 weighted imaging, and then after injection of contrast into the lymphatic system, it also leaks directly into the left pleural space, causing chylous effusion. So both plastic bronchitis and chylous effusion seem to have this similar DCMRL appearance of retrograde lymphatic flow to the lungs. In this case, we actually saw lymphatic leakage into the pleural space, but you don't actually need to see that to make that diagnosis. If you have chylous effusion and you see this retrograde lymphatic pattern into the lungs, that itself can be diagnostic for being the cause of this chylous effusion. What is the value of MRL in these cases? Here is another patient with a single shot. You can see this lymphatics in the hilar regions. And in this case, it's not as a profound abnormality as the previous one. There are just a few abnormal collateral channels that go into the left hilar space. And these can be selectively cannulated using conventional lymphangiography and embolized. So MRL helps identify suitable targets for intervention and also allows for pre-procedure planning. Sometimes we do the MRL and directly afterwards go directly to intervention in the same anesthetic. Also, it's not always as straightforward as I've shown you. In Fontan, it typically does adhere to the pattern you would expect, but especially in these, other congenital lymphatic abnormalities, you can have really weird lymphatic collateralization or drainage patterns. For example, in this case, in the literature, there is no lymphatic duct, but you have the cause of this lymphatic retrograde perfusion is from the hepatics. So if this patient has pulmonary lymphangiectasia or lymphatic problems causing respiratory symptoms, then it wouldn't be the same pattern. We would have to cannulate these hepatic lymphatics. So lymphatic collateralization patterns can be variable. And again, the DCMRL defines abnormal perfusion to help guide therapy. So summary of plastic bronchitis. In most cases, plastic bronchitis after Fontan is related to retrograde lymphatic flow to the lungs. And T2 imaging can delineate the abnormal lymphatics on routine CMR. And the dynamic contrast enhanced MRL can identify the retrograde lymphatic flow, which can be helpful for identifying suitable targets for potential intervention. So now let's go on to PLE. So what is PLE? As you guys probably all know, it's abnormal loss of serum proteins into the intestine. And most of this is from lymphatic or mucosal abnormalities most of the time. So you can have congenital PLE, but I'm going to focus on Fontan-related PLE. But before we get into that, let's think about what are some of the features of liver lymph. So liver produces 25 to 50% of lymph flowing through the thoracic ducts. So a lot of it. And this is different than other lymphatic fluid because it has high protein concentration, whereas the other lymphatic fluid has very low protein concentration. So if you're talking about loss of albumin, you know it's coming from liver lymph. Hepatic lymphatic ectasia and proliferation correlates with fibrosis and cirrhosis. However, PLE is almost always absent in non-cardiac cirrhosis. And that's probably because there's normal GI lymphatic circulation in those non-cardiac cirrhosis patients. So this speaks to a lymphatic problem again with PLE. Also, there's high prevalence of PLE in Fontan patients with thoracic duct ligation, again, speaking to the lymphatic origin. And intestinal lymphangiectasia biopsy, again, implicates the lymphatic system in PLE. So this is all, so the liver lymphatics are strongly implicated in the development of PLE after Fontan, but this is, pretty much well known now. So what are we talking about here? So in the normal situation, the liver has two paths of lymphatic drainage. There's central lymphatic drainage to this cistern or chyli up to the thoracic duct, and then a peripheral system that drains to the IVC. There's also, as I mentioned, drainage from the mesenteric lymphatics into the cistern or chyli. So in Fontan, the lymphatic drainage is impaired, and you'll have collaterals from the liver lymphatics, especially the central liver lymphatics, into the duodenum, and potentially also from the mesenteric lymphatics also to the duodenum. And this leads to PLE. So we can see this. So if during duodenoscopy, we can inject dye into the liver lymphatics, and very quickly in these patients with PLE, you'll see staining of the duodenum with this dye. So the pathogenesis is very similar to what I showed you before. You have elevated central venous pressure plus elevated hepatic venous pressure gradient, sometimes liver fibrosis, more lymph and impaired drainage, duodenal lymphatic collaterals, and then lymph leakage into the duodenum. Again, there may be inflammatory triggers, and the pattern of collateralization plays a role. So let's see what we see on MRI. Let's look at what we see on MRI. So conventional MRI imaging, we see this periportal lymphatic proliferation. We can see ascites. We can see this significant mesenteric lymphatic proliferation. And again here, very abnormal mesenteric lymphatics in patients with PLE. But all of these findings are nonspecific and can be seen with just congestion alone. So that's where MRL comes into play. So here's a T2 MRL in the patient with PLE. You can see significant mesenteric and periportal lymphatic congestion. When we inject into the hepatic lymphatics, there is very, very quickly retrograde flow into the mesenteric region and frank extravasation of gadolinium out of the liver lymphatics into the duodenum here. So on source images, you can see that this gadolinium is completely filling the lumen of the duodenum. So intrahepatic DCMRL shows duodenal leak, and importantly, this duodenal leak was not seen on intranodal DCMRL, which only opacified the retroperitoneal lymphatics and thoracic duct in this patient. So you have to do both. As you guys probably know nowadays, people are doing catheter-based intervention, and so are we. So in this patient, you can cannulate these hepatic lymphatics in the right and left hepatic lobe, try to push deep into these collaterals that go to the duodenum, and then glue embolize them. And this has shown promising early results both in the literature and in our own patients. Here's a case showing intramesenteric DCMRL in the patient with PLE. In this case, it was actually the collaterals were more from the mesenteric side than from the hepatic side. And so again, you can see on the anatomic imaging, you can see the abnormal mesenteric lymphatics. And then injection of gadolinium into the mesenteric lymphatics shows a leak of contrast directly into the duodenal lumen here. Again, completely filling the proximal duodenal lumen. And then here we try to glue embolize those as well. So PLE summary, it's in Fontan, it's usually due to leakage of liver lymph into the duodenum via hepatoduodenal collaterals. Conventional imaging features of PLE are nonspecific, but T2 MRL and dynamic contrast MRL can delineate these abnormal lymphatics, and catheter-based intervention is an emerging treatment option with promising early results. So I'll just show you some other pictures. This is not a Fontan case, but a patient that had some nice imaging of showing congenital chylous ascites. So you see this 6-month-old with a lot of ascites, congenital chylous ascites. We do INDCRML, and then there's frank leakage from the retroperitoneal lymphatics directly into, or subhepatic lymphatics directly into the peritoneal space. And this was occluded through Lepidol. Basically, there's some Lepidol in this gadolinium, and that already has a little bit of a scarring property, which was enough just from the DCRML to occlude that site of leakage. Okay. I'll show you a case of dermal backflow. This is also not a Fontan patient, but a patient with congenital cholecystitis, and had a lot of scrotal swelling. And you see the DCRML or the T2-MRL showing this abnormal retroperitoneal lymphatics and a lot of ascites. And with injection of gadolinium into the groin lymph nodes, there is a pacification of these abnormal lymphatics with a very tortuous, dilated thoracic duct, but also abnormal lymphatic uptake with retrograde flow into the scrotum, causing huge congestion into the scrotum. All right, so let's move on to some of how this can be used for surveillance or predict outcomes in single ventricle. So there have been a couple papers now out of the CHOP group, which have looked at using T2-MRL as a prognostic marker in the pre-Fontan situation. So on the pre-Fontan MRI, they classified the lymphatic pattern in 3 types: either no abnormality, some mild abnormality. So this is BCPC stage. So mild abnormality in the supraclavicular region, lymphatic abnormality extending into the mediastinum, and then frankly, in really bad lymphatics extending into the lungs as well. And during using this classification, they found that type 4 had progressively longer, well, type 3 and 4 had progressively longer duration of effusions and hospital stay, and actually type 4 had almost universal takedown, either takedown or transplant. I think it was 100%. I have to check that again. They did a follow-up paper which did basically the same thing, and looking at not just takedown, but more factors, more markers of morbidity. And type 3 and 4 had much longer complications, including greater chest tube duration, readmissions, re-intervention either through cath or surgery, need for ECMO, or transplant listing, takedown, or death. So basically, the pre-Fontan lymphatic pattern predicts risk of early post-Fontan morbidity, and type 4 has a really high Fontan failure rate, including death. This other paper came out recently looking at lymphatic surveillance post-Fontan. So in a similar way to the CHOP group, they classified the lymphatic pattern in the thorax, in the retroperitoneum, and also in the liver. And basically, the worse your lymphatics, the lower your serum albumin. So worse lymphatic congestion is associated with lower serum protein, and so that could be a prognostic factor as well. Our group has been trying to quantify these lymphatics. So we use threshold-based segmentation of the T2-MRL, and we found very high inter-observer reproducibility. And so semi-automatic thresholding-based segmentation is feasible and provides a reliable surrogate measurement of lymphatic volume. And we found kind of in a retrospective manner that patients with history of adverse event had much worse lymphatics. So lymphatic burden may potentially in the future help predict Fontan outcomes and guide clinical management. So that's basically the talk. In summary, there's 2 main MRI techniques to image lymphatics. There's T2-MRL, which is non-invasive and provides anatomic assessment. And then there's dynamic contrast enhanced MRL, which is invasive and provides dynamic assessment. The DC-MRL can help map the lymphatics and help guide catheter-based intervention in Fontan. In plastic bronchitis or callus effusions, this manifests as retrograde flow to the lungs. In protein-losing enteropathy, this usually you'll see duodenal perfusion or leak, and in cholecystitis, you'll see peritoneal leak. Finally, at the end, I briefly showed you emerging data that supports how MR lymphatic pattern and burden has potential as a prognostic imaging biomarker in single ventricle disease. That's it. I'd be happy to answer any questions. Thank you.
Thank you so much, please. Yeah, so I was writing in the chat. There was one question from the audience about the type of contrast that you use for these tests.
So for the MRI test, it's just a basic gadolinium, so basic MRI contrast agents.
Okay.
But for conventional or CT lymphangiography, you'll be using iodinated-based contrast agent.
All right. I'll give the word to Elena Raffo, who's the expert here in the cardiac radiology. You need to come here.
Volevo chiedervi, scusate se mi fai la traduzione, in inglese è molto chiedi tu perché...
Which kind of coil do you use?
The coil? It's just a I think it's just a normal flex coil.
Like a 32 channel or?
I'm not sure, honestly. I can check for you if you're very interested.
How long does it take this?
Infatti la seconda domanda è...
How long does it take for you to perform the entire scan?
It varies depending on which areas we're going to interrogate. But typically, it's a long exam, probably like 4 to 6 hours.
Oh.
Well, the exam itself is shorter, but there's time where GA time, and then they have to cannulate all the areas, and then we start to scan. So the scan itself is shorter, but the GA time blocked is about 4 to 6 hours.
And do you perform a cardiac MRI before, and then the lymphatic one in the same shop?
So sometimes we will do the lymphatic. So oftentimes we'll do a cardiac MRI first for Fontan, and that will have the T2 MRL. And then later we will do a dynamic contrast enhanced MRL separately under GA, because the Fontan cardiac MRI is non-sedated. And in that case, we'll also do the cardiac hemodynamics. So then later we will bring them back for a dynamic contrast enhanced MRL specifically if they have Fontan failure. And that in that scenario, we may proceed directly to catheter-based intervention after the MRL and under the same anesthetic.
Okay. So you have the cath lab near to the MRI. Yeah.
Well, we do it with the interventional radiologists, and so yeah, it's in this. It's a combined. It's not combined, but it's very close together.
Okay.
So I see that also Raffaella Motta is connected. She's a professor of radiology here at the University of Padua. I don't know if she has any. Raffaella, do you have anything to say? In the meantime, we have here Giovanni Di Salvo. He's the head of the cardiology unit. Maybe he wants to say something.
Thank you very much. Beautiful lecture and great images. Very fascinating and inspiring. Just one question. For such long exam, 4 to 6 hours, how you cope with your patients? I mean, I guess Fontan failure patient to send magnet for 6 hours or for 4 hours, it's quite long, it's difficult. Do you have experienced any problem, any complication during the scan?
No, we haven't had any complications. It's under anesthesia, so they're not awake.
Okay, so that's okay. Under anesthesia. Okay, thank you.